Good morning, and thank you for allowing me to join you and talk this morning. I was asked to discuss my experience with alternative medical practices that can be useful in hospice and palliative medicine. I don't have any financial disclosures. For those who aren't familiar with me, I spent almost a decade doing surgical oncology for Corewell, and to this day continue to do some general surgery. During my time doing surgeon, I felt like I wasn't providing my patients with all the treatment and medical care that I could, and also wanted to become more proficient at having discussions regarding extensive surgical treatment and its implications. So I chose to do the Hospice and Palliative Fellowship at Mercy in 2019. I spent my elective with a chiropractic neurologist and was introduced to the field of functional neurology and learned some craniosacral therapy techniques. I started incorporating both of these into my surgical practice because I was seeing a lot of patients with chronic abdominal pain. What I found is that a lot of people ended up leaving my office feeling a lot better than they did. And the results were a lot more durable than they were with the surgical treatments I was offering. For the last 2 years, have been doing medical nutrition as well, and over the past year, completed training in integrative health. So this morning, I'm going to go over some definitions quickly, and those will be helpful in the discussion. I'll then review some alternative approaches to symptom management. I have a couple cases of my own that I wanted to present to you, and then finally I'll just this is a person as a whole, a growing field with several trainings throughout the States and with complementary and alternative practices like traditional Chinese medicine, homeopathy, mind-body practices, nutrition, and bio-individualized medicine. Orthomolecular medicine is a paradigm that focuses on nutrition, diet, and supplements to promote health and wellness. These are a few more definitions, some modalities, which I'll discuss in further detail later. So functional neurology, or what I like to call neurovestibular rehab, is applying clinical neuroscience to address complex issues. And many of these issues are often not typically defined or not typically recognized as neurologic issues. Craniosacral therapy is a gentle touch that's used to balance the nervous system by influencing the bones of the skull, other tissues of the body, and the cerebrospinal fluid. Because the nervous system controls everything, craniosacral therapy can have an impact on the cardiovascular, endocrine, reproductive, and GI systems. Visceral manipulation is another manual therapy that uses light touch to identify the intrinsic motion of organs and correct any abnormality present. It's pretty exciting to place your hands on somebody's head and be able to feel all the way down to the level of the ventricles and the way the spinal fluid is flowing within them. Similarly, individual pulmonary lobes can be felt, and once synced up, the patient will often take a spontaneous and very deep breath. Hyperbaric oxygen is probably the modality here that you're most familiar with, and this involves placing a patient in a pressurized chamber and allowing them to breathe pure oxygen. The increased oxygen saturation and partial pressure within the blood then allows for more efficient delivery to the tissues. A great example of usefulness is a patient with a crush injury to an extremity. A pulse oximeter is typically placed on an unaffected part of the body and can read 99 or 100%. But what do you think the oxygen saturation within the injured body part is? Probably half of that at best. Wouldn't it make sense then to supersaturate the blood to ensure adequate oxygen delivery where it's needed? So I'll now go over some symptom management. Pain is the most common thing for HPM providers, so I'll start there. You've had extensive discussions on opioids and non-opioid analgesics, so I won't go into that. And I believe Dr. Emery talked to you last week about mindfulness, which is a pretty powerful way to take a step back from the pain experience and it can be useful in both acute and chronic pain. Many of you have heard about the usefulness of acupuncture, massage, and aromatherapy in pain management as well. Hyperbaric oxygen is not something that I used to think of as a treatment for pain until I got my chamber. My mom had suffered with undiagnosed seronegative RA for a long time. Methotrexate and actually some dietary interventions had improved her pain control, but it was still a significant issue. After 20 minutes of being in the chamber the first time, she said her hip pain completely went away and it was gone for a full 3 weeks before starting to gradually come back. She now uses oxygen with a concentrator at home for about an hour twice a week with near complete control of pain. Hyperbaric oxygen, or HBOT, can be delivered in 2 different ways. The first is standard HBOT, which is what you'll find in a decompression chamber or used in the hospital for wound management. The other is mild hyperbaric, or HBOT. This is only 1.3 atmospheres, which is the equivalent of about 10 feet below sea level. The benefits of any type of hyperbaric oxygen therapy is that it diminishes the inflammatory response, increases immune cell function, decreases cytokine response, and promotes vasoconstriction, which can reduce swelling and edema. It's been found that intermittent hyperoxia with a hyperoxia and relative hypoxia cycling is more beneficial than just a one-time exposure, and it can take up to 20 or 30 sessions to see a benefit. It's also been demonstrated that after stopping the therapy, the effects continue to increase for some time. The next thing to talk about in terms of pain management is neurovestibular rehab. It's important to understand that pain is the experience and is not directly proportional to nociception. So you could have tissue injury with no pain. You could have tissue injury with appropriate pain. You could have tissue injury with exaggerated pain, or you can have no tissue injury, and still have pain. One way to explain this model is the gait control model, which was proposed in the 60s by Melzack and Wall. The different components of this theory are understanding that the pain signal is transmitted to the spinal cord through C fibers and A delta fibers. And then within the spinal cord, there's a gate in the dorsal horn, which modulates the signals coming in. There are also large or A beta nerve fibers that transmit the non-painful stimuli. Yet the gate within the spinal cord is integration of these painful and non-painful signals coming in. This helps explain why when your child bonks his head on something, you immediately go over and give him kisses around where he got hurt. Likewise, if you bang your shin into something, you reach down and start rubbing the area around it. These actions help increase the non-painful stimulus through the A beta fibers, which will downregulate the transmission of the signal from the C and A delta fiber stimulus. So it either doesn't reach the cerebral cortex or is attenuated. There's a final component which is very significant, and that is descending modulation from the brain. A lot of this comes through the PMRF, or the pontomedullary reticular formation, and the periaqueductal gray matter. These different areas, the descending modulation from the brain, and then increasing the stimulus through the large A beta fibers, are some of the areas that I focus on when treating pain from a neurologic basis. This gate control theory, as I mentioned, is seen at the spinal segmental level, as well as descending cortical output. But the sensory cortex also plays a big role in pain perception for obvious reasons. Additionally, the frontal lobe, in particular the anterior cingulate cortex, is important in pain modulation, which we know from the significant impact emotion can have on pain perception. I mentioned before the PMRF, which has descending pain inhibitory control and is influenced by the cerebral cortex. And then the cerebellum, which integrates throughout the brain, but maybe most importantly for this discussion, on the periaqueductal gray area. This picture is just one conceptualization of the way movement and pain can be related, and is useful in how I approach treatment from a neurologic standpoint. If somebody's in severe pain, I may start out by just determining whether or not they can tell left from right. And then from there, we move to motor imagery, which involves imagining a particular movement as non-painful or watching someone else do the movement without pain. You may be somewhat familiar with mirror therapy, and it can be used by placing a mirror that blocks a hand that is painful, for example, and then having the patient use their other hand to do whatever motion is painful while looking at the reflection in the mirror. The brain then perceives this as if the painful hand is moving in a non-painful way, and it can start to reset the circuitry that has been promoting the motion as painful. Once pain can be reduced, we would start with passive movement and then have the patient start moving in an isometric fashion before moving to motion with a load. Craniosacral therapy is another treatment I use frequently to treat pain through a variety of applications. First of all, it can increase the CSF turnover, thereby improving the supply of nutrients to the brain and spinal cord. This treatment is also beneficial in autonomic regulation, which can improve cardiovascular, digestive, and reproductive health. One commonly used application is called regional tissue release. And if there are any osteopaths in the audience, you may be familiar with the term unwinding, which is very similar. Regional tissue release generally involves holding a body part or tissues between two hands and allowing for any tension within primarily the fascial system to release. It's within the fascial system that a lot of tension is held, and also where a lot of pain fibers are transmitting signal from. Another technique is called pendulation. To explain this better, I'm wondering if there is anybody who's willing to volunteer for a little demonstration. Should be somebody who has maybe a painful spot that is chronic and can't really figure it out or get relief from anything else. It's okay. If nobody wants to volunteer, I can just describe it to you. The technique is actually probably most useful with a hands-on application because as a practitioner, I can feel the craniosacral rhythm and respond and adapt the therapy depending on how the craniosacral rhythm is changing. So,
Andrea, we have a volunteer in our room here.
oh, excellent. Who is it?
Me, David.
David. Okay, David, tell me a little bit about your pain.
I mean, I get a lot of upper back pain when I wake up in the morning. I assume it's from kind of how I'm sleeping.
Okay, and is it located more centrally or out to the sides?
It's more central.
Okay. Do you have it right now?
Maybe a little bit mild, but not too bad today though.
Okay, where is it, or what level of pain would you give it?
Yeah, right now it's pretty mild, so I'd say like 2 to 2.
2, okay. And can you describe it at all? Any characteristics?
Yeah, I'd say it's more sharper and it's kind of medial to the shoulder blade area, kind of worse with certain movements.
Okay. Does it have any, even not a typical pain descriptor, but like a pulsating, or can you associate maybe a color with it or an emotion?
Not necessarily.
Okay. All right, so we focused on that for a moment. So now let's survey your body and see if there's an area that's completely benign, a neutral, non-painful spot.
Yeah, I mean, I don't feel too much pain in my legs.
Okay, so one leg over the other?
They're both pain-free right now.
Okay, and again, similarly, is there any emotion or other qualities to that non-painful area?
Well, I feel good about it not being painful, so positive.
All right, so positive feeling there. All right. And then we'll kind of go back up to the area in your upper back that's painful. And has that changed in quality at all?
Right now, I think it's still mild, you know.
Yeah.
I'm not sure if it's too much different.
Okay. All right. So we'll kind of go back down and focus on the legs again and just noticing that area and being aware that it's a positive feeling, free of pain, and able to move in the full range without discomfort. Is that right?
Yeah.
Okay. Has that description changed at all?
Of my, no, that's correct, my legs, yes.
Yeah. Okay. All right. Then we'll kind of go back up to the area in the shoulders and see if there's any difference that you can notice in that area.
Well, I think, focusing on my legs, I'm definitely not thinking about my back.
Okay, good. All right. So this is kind of what we would do with pendulation. We're focusing on the site of pain and then quantifying it, qualifying it, and then going back to a neutral area and just kind of going back and forth. And this process generally takes less than 15 minutes. And if we were kind of more in a controlled, relaxing environment, we might notice that the pain in your shoulders went down to a 1 or even a 0, hopefully by the end of that kind of bouncing back and forth. So it's a nice application to address any chronic issues that we're not seeing any improvement from with other modalities. Thank you, David. So the last application here in pain management is infrared light. This is a device that I use. It's from a company called Gladiator Therapeutics, and inside each of these little bumps is a ceramic disc. This particular unit is intended to be applied to the abdomen or back, but they have similar ones that are N-shaped ones that will fit over the shoulder, knee, or around the wrist. I think there might even be one that goes on the head, kind of like a cap. And the idea is that body heat will heat up the ceramics that then emit far infrared light. And with several applications, the infrared light can actually reduce inflammation and therefore pain. One of the principles of using these therapies is that, yes, each one individually can be beneficial, but layering one on top of the other can enhance the effects of each significantly. Were there any questions on the pain management section?
I think there's lots of questions in terms of just, I'm personally finding this fascinating in terms of the things that many of us have not really experienced in real life. And so I'm perhaps, as we get to the end, if you can give us some real life cases, if you've got them,
Yeah.
to just kind of demonstrate how you use these, perhaps how you've done the layering, how you've applied some of these different techniques in different circumstances, I think would be also very instructive.
Yeah, absolutely. So another common set of symptoms is nausea and constipation, where we're all pretty well versed in what pharmaceuticals can be used, but there's a number of different herbs, including ginger, licorice, fennel, peppermint, slippery elm, lavender, and chamomile. The majority of these can be used for both nausea and constipation, and there's other ones that I didn't list. Senna and aloe, as well as cascara, are also stimulant laxatives. Acupuncture and acupressure are pretty well documented treatments for nausea. This is a picture of C-bands, which you guys are probably familiar with. They're basically an acupressure device that's worn around the wrist about 2 or 3 centimeters below the wrist crease on the volar aspect. And that's the Mequon or P6 point used in acupuncture. Neurorehab is, again, a useful treatment modality particularly for nausea. This diagram is a little bit complex, but you can see up to the left side, just next to the organs, is the DMV, which is the dorsal motor nucleus of the vagus. This is a therapeutic target because vagal stimulation can improve nausea and also bowel function. In the middle is the NTS, and below that the CTZ, which stand for the nucleus tractus solitarius and chemoreceptor trigger zone, respectively. The CTZ is the target of many antiemetic drugs, which thereby downregulates activity in the NTS. A primary target for neurovestibular techniques for controlling nausea is the cerebellum, using the vestibular system with different exercises, one of which is called zero viewing, in which the patient would hold their thumb out in front of them and look at the thumb while rotating in a chair to the right or left, depending on what the examination shows to be the best direction. Gaze stabilization exercises can increase the output of the Purkinje cell network, which also will downregulate the NTS. Visceral manipulation is used particularly in my practice for constipation, but it can be used for nausea as well. It involves listening to the organs with, again, just gently laying hands on the skin or over the clothes, and trying to reestablish a normal rhythm to the colon or stomach. Oh. Fatigue. Who doesn't suffer from fatigue? Stimulants and steroids are helpful, but what if we could use diet or nutritional supplementation and get the same results? B vitamins, vitamin A, and vitamin C are all implicated in increasing energy. Looking at adrenal gland function can be useful to determine if providing herbal treatments to increase adrenal output in the morning and decrease adrenal output in the evening can establish a more normal cortisol levels throughout the day. A lot of times patients have a tired and wired pattern where they're tired in the morning and much of the day, and then they're wired at night and can't fall asleep. And this is because the cortisol natural fluctuation is off, being low in the morning and high in the evening. These are, I've listed here a few of the adrenal adaptogen herbs, and antioxidants can also be useful for improving mitochondrial function and therefore energy production. Dyspnea is pretty common in a number of disease conditions. Obviously, oxygen and opioids have been the mainstay of conventional medical treatment, but osteopathic adjustments can be useful as well as meditation and breathing exercises. There are a number of acupuncture points running along the lung meridian from the tip of the thumb along the lateral volar forearm up into the upper arm, and these can be useful in the management of symptoms. The traditional Chinese medicine approach would be to treat the underlying disease state before addressing these specific acupuncture points. However, they can be very effective when used appropriately. A patient could be asked to run a finger along the lung meridian, and if a painful location along there is identified, pressure or massage can be applied to that area. I've used the craniosacral therapy for dyspnea a number of times. The treatment is similar to regional tissue release that I was describing earlier, and this can be applied to release tension within the respiratory diaphragm or the thoracic inlet.
Andrea, do you find that the use of these therapies varies dependent upon what the cause of the dyspnea is? I'm wondering, people that have fibrotic disease versus COPD versus cancer versus, pleural effusions and things of this sort. Are there places where some of these interventions are more effective for the specific type of dyspnea that they might have?
Right. Yeah, that's a really good question. I think it definitely does depend. I haven't had the opportunity to see a lot of patients who have those severe COPD or fibrosis. But I think the visceral manipulation would be very effective for allowing the lungs to move in a more natural rhythm and to also get the lymphatic flowing within the lung to clear out any thing that may be contributing to the disease process itself. And then kind of in terms of maybe a restrictive pattern, the craniosacral therapy is going to be more effective by releasing the tension within the chest wall and diaphragm. Good question. Well, anxiety and depression's pretty common in the chronically ill population. We often use the antidepressants, benzodiazepines, and antipsychotics along with anticonvulsants. I've found a number of patients benefit from hyperbaric oxygen as well. They describe a sensation of relaxation while in the chamber that lasts for several days. I have one lady who got a series of treatments. She only has done 11 so far, but then she took a 3-week vacation and still hasn't been chomping at the bit to come back in, even though she was coming in really regularly because it was so beneficial for her at the beginning. But I think once she completes the 20 visits, she'll probably have benefits that last several months. With the neurovestibular applications, the theory is that error within the nervous system, such as a mismatch between information coming from the eyes and the vestibular apparatus, is a cause for an increase in sympathetic response. Therefore, if we can decrease error by correcting a sensory mismatch, the anxious feeling will also be reduced. The mesencephalon plays a significant role in regulating sympathetic output, and it can be downregulated through various treatments. Finally, nutrient supplementation is gaining popularity as a treatment for anxiety and depression, with a particular focus on B vitamins, vitamin D, and selenium. There are a number of brands of broad spectrum micronutrient supplements that can be used to deliver vitamins, minerals, and antioxidants with results similar to or even surpassing that of antidepressants. Finally, herbal extracts are very effective. Pretty much everybody's familiar with St. John's wort for depression, but lobelia, sweet chestnut, and lavender can also be very useful. Insomnia is a common complaint among patients undergoing medical treatment, and using traditional pharmaceuticals for short term can be beneficial, but I encourage patients to explore mindfulness and meditation. These are effective ways to calm the mind. There are a number of neurofeedback and biofeedback devices on the market. This one here is a band that's worn around the head. It's called Muse, and it can provide information or feedback based upon what the brain waves are doing. And there's a variety of different programs for focus, calming the mind, sleep. So it's quite useful for a number of different conditions. Herbs and supplements are very beneficial. Couple of favorites of mine are magnesium and B vitamins. Again, getting the B vitamins to help with the metabolism of the nervous system, and magnesium can have a calming effect, as well as the other supplements that I have listed there. Finally, looking at the individual's chronobiology can be quite useful. This is chronobiology is the interplay between our internal clocks and environmental cues, particularly the light-dark cycle. Chronotherapy refers to the timing of medication administration to align with an individual's chronotype. I've listed here some common medications that you might use and how their effectiveness can be altered by when they're taking. I thought it was particularly interesting to learn about chemotherapy and how different drugs can be administered at different times of the day. And it's also dependent upon the chronotype. So whether somebody's an early bird or a night owl may indicate that their medications should be delivered at a different time of day. So I'm going to go through some case studies. This first one is Tim. He's a 27-year-old male teacher. He was having increasing discomfort kind of over the course of about 7 years. It was primarily right-sided. he had a lot of muscle spasms, which were characterized as dystonias, significant fatigue. He also had mouth sores, some trouble sleeping. So a lot of different things. He ended up coming and spending a week with me doing 3 or 4 treatments of various types throughout the week and left significantly improved. And it was interesting because he'd been to neurology, rheumatology, psychology, and was going to be going to psychiatry. And at one particular point, I was testing him, and then I applied a treatment, and the thing that was off was that when closing his eyes and looking, if I turned his head to the side and then with eyes closed still, he couldn't bring his head back to center. It was always off to the right side. And so then I applied some treatment to increase the left vestibular input, and his correction back to center was spot on. And he opened his eyes and looked at me. He goes, I've been to so many doctors, and especially the neurologist. They come in, they slap one arm, they slap the other arm, and then say, here's a pill. And you did this in just a couple seconds and actually got a result from it. So it was kind of a cool outcome from that. The other one thing that we were working on, I had mentioned that he was having a lot of spasms on the right side, and he was unable to raise his right arm even to shoulder level. So I applied some optokinetic stimulation to the left, and he had about 100-degree improvement in abduction of his arm. So he was able to raise it up pretty much all the way to his ear without any pain. Next patient is Becky. She's a 47-year-old female with multiple sclerosis. A lot of spasticity in her legs on the right more than the left. She'd not really been aware of vertigo and imbalance until I started asking her about it, which is very common with a lot of patients that I see. But she did have one day where she was very dizzy, and just through messaging with her, I was able to give her some exercises to do at home, which improved the vertigo, but it was still there. So she came into the office, and that day and on previous times that I had seen her had also complained of some occipital headaches. So we started with a nutrient infusion, which I think in certain patients is important to get the nervous system the nutrients that it needs prior to starting therapy. We then did some craniosacral therapy, which in this session and in all of the previous sessions that I had done with her improved her gait significantly. We were also able to resolve the headache that had been present for several weeks. We then proceeded with some neurovestibular rehab, and this again involved activating the labyrinthine system on one side that had been underactive. She was started out when I did a Romberg test, and immediately upon closing her eyes, she just fell backwards and actually couldn't even catch herself. After doing the vestibular integration, she was able to stand perfectly still without any sway at all. She also had some decrease in the spasticity, and this was partially improved with the vestibular techniques, but then also just doing some sensory stimulation, which helped integrate through her sensory cortex. And then what I proposed was that it was that she wasn't getting appropriate feedback, proprioceptive and otherwise, to the sensory cortex. But once we started stimulating it, the improved sensory feedback was then able to decrease the spasms, because the spasms were partially there because they were trying to, again, increase that sensory input into the brain. So another reason why I like to incorporate integrative practices is that medications are actually toxic in some respects. The majority of tablets have talc in them, and I discovered that that is used because the drug itself will not bind to other drug particles, so they need the talc to fill in between and allow the cake to form into a hard tablet. Some medications, particularly topical and ophthalmic formulations, include mercury. There's still bromine in some medications, and the problem with bromine is that it will competitively inhibit, or I guess it is a competitor for iodine in thyroid hormone production. So it can decrease thyroid hormone production. And then phthalates are in some medications as well, particularly the long-acting or sustained release formulations. Artificial dyes are used in a lot of meds just to give them the color to distinguish them from other medications. These are petroleum-based products, and they have been linked to hyperactivity. Another thing that I learned recently is that antipsychotics like olanzapine actually have been shown to decrease cortical thickness, which is not ideal. Then I've listed on the other side some drugs that are known to deplete these particular nutrients. So a lot of the vitamins and minerals that are necessary for appropriate cell function are being depleted by the medications that we prescribe every day. And it's not to say that those medications shouldn't be used, but they may need some supplementation along with them to make sure that there's adequate levels circulating and available to the tissues. One particular one that I wanted to point out is metformin, and that depletes B12 levels. And so a lot of times we're taught that it's the diabetes that causes neuropathy, but we should also consider the fact that maybe it's actually a B12 deficiency after years of use of metformin that's causing the neuropathy. That's all that I had, but wanted to just kind of review that there's some multiple alternative treatments available to address a lot of different symptoms, even more than I did listed here. The underlying cause of symptoms are being treated that can provide a more durable result, as opposed to seeing a symptom and just providing a medication. These alternative treatments are actually getting at the root cause of why that symptom is there. And then again, reiterating that medications can deplete nutrients that are pretty essential and may be exacerbating what you're trying to treat. Thank you. I'm happy to take any questions and discussion.
Let's start with what's popped up. A couple that popped up in the chat, Andrea. So we'll start with those, and I'm sure others have questions as well. First, is the Gladiator infrared therapy covered by insurance, or is that out of pocket?
It would be out of pocket.
Yeah. And
if somebody came into my office, I could, I don't bill insurance, but I can give them a billing code for the time portion of it, because I would be doing other therapies at the same time.
Yeah, I find it fascinating that here, it kind of reminds me of the a lot of things behind the curtain that we're not necessarily aware of, and we're sort of stuck in the box that we have been trained in through traditional Western medicine using, interventions that tend to be, pharmacologic in nature, not recognizing or realizing that there are some really interesting and effective options out there that we're simply not aware of. That's one of the things I was so glad you're able to do this, because I think this awareness is such an important expansion of our the armory that we have in terms of resources to help our patients. And
Yeah, same thing for me. I mean, even doing all of this stuff, I'm constantly finding new modalities and I'm like, oh, I want to learn that. Oh, I want to learn that. So there's, I mean, it's just grows exponentially.
Yeah. Another question, can optokinetic therapy for shoulder pain be self-applied? And if so, might it help a structurally intact labrum that is limited beyond the midline?
Absolutely. I think it would take somebody trained in optokinetics to know exactly what direction to do the therapy in. But I give that to patients often. There's a app called Optodrum. I'll put it in the chat. That it's basically just on your phone an optokinetic stimulus that depending upon which canal system is downregulated, then we would apply the therapy in that way. And it's very much applicable to limitations in range of motion.
Thanks. Other questions that the folks have that they'd like to pose to Andrea? You can release the screen if you want there.
Oh, okay.
I have a question. I have a question, Andrea. Oh,
Yeah.
gosh. Yeah. So how do you, I mean, part of the issue is that we just don't have the, the regulation of the herbs. Like, how do you know, or how do you decide
Right.
which herbs are affected? I mean, how is that? How do you navigate that challenging piece, right? I mean, St. John's wort is not just St. John's wort. I'm assuming that it could vary from what you buy and how that's used. So how do you navigate that piece?
Right. Yeah. No, I'm glad you asked that. A lot of what I base my recommendations are on, and I actually don't even use St. John's wort, but a lot of it is based on Ayurvedic and Chinese medicine, and basically what's been used for centuries or millennia. And these therapies that have kind of that cultural knowledge, but in terms of like the purity of the herbs and everything, there's a few companies that I go through, and I don't use, I actually tell patients don't buy anything over the counter. You need to get it from these reputable sources and make sure that the purity testing has been done and documented.
And do you have a list of those? I mean,
Yeah,
that
I'll
have
put them in the chat too.
Would you be willing to share that? I mean, just, for some of our patients who want to go a more natural route, I just never know what to recommend or how to guide them, and that would be super helpful.
Yep. Yeah, I just put those in the chat. Those are the two brands that I use the most.
And I will make sure that I get that. I'll include that in the YouTube post. We're now, for those of you that are up on our YouTube channel where we post these lectures, we now are posting the PowerPoints and any documents and any additional information on that channel. So you can go into that link. You don't have to listen to the whole lecture again unless you want to, which I probably will because I want to, but you can just click on the links to the documents and get that information as well. And to that point, Simi, one of the things that's fascinating to me, I did a lot of medical relief work back in the 90s, mostly in Eastern Europe, Southeast Asia, and Africa. And in Southeast Asia, I'd be in these small rural towns, and you'd go into what I would put in quotes, the pharmacy. And as opposed to our pharmacies where I have these racks of large bottles of pills, which they then, put into smaller bottles of pills and hand you. What you have are these bins and baskets
Mhm.
of plants and herbs. And you go in and it's not too dissimilar in that there's a prescription that has been written by the practitioner. And they'll reach and they grab some of these roots or grab some of these things and they grind them up and they give them to you with instructions on how to use it.
Mhm.
And I was fascinated by that. And I think what's happened is that, our traditions in Western medicine have tried to take the value of those and adapt them to our policies. I think that it would be really weird for people to go into Walgreens and get a handful of leaves that are ground up and expect to know how to effectively use those. So we've adapted those. So if we'll go into a factory and we'll do our own, standardizing of that and put it with the talc and the bromine and the everything else that we have to put in those pills, and then sell it to you in some sort of a standardized form, which has no scientific validity whatsoever. And so I have, just because of my observations in that work, have seen the benefit of that. There's still a pretty big gap between how we can apply something in a manner and a form which is acceptable to the standard US population. And by the way, is affordable to people. The thing that mystifies me is that so many of these things are straightforward, they're effective, they're not invasive, and it doesn't necessarily require a lot of, yes, there is some equipment, you got the hyperbarics, and you got some of the other devices, but they're not technically, other than the time of the practitioner, not that expensive to apply. And yet we don't have coverage for our standard insurance companies to pay for that. So it then becomes out of reach for some folks who use it the most. And that's more of a political commentary than anything else.
And Andrea, one more question about drug interactions.
Okay.
Is there a reliable source for drug interactions? Sometimes I'll look it up on UpToDate, but is there a resource for drug interactions with these herbs and traditional, especially I'm thinking of like cardiac meds, a lot of our patients are on them, and I don't know, I mean, is it okay to take, ashwagandha or what? I mean, I think, I don't know.
Yeah, I haven't investigated each individual herb, but there are some some of the sleep preparations contain 5-HT, so you don't want to give that to anybody who's on a SSRI. And then, one of the other ones I was thinking of in particular, but honestly, I use the NCBI search, and then I've also recently started using AI to investigate those things because I get a lot of good responses, and then I can go from there and investigate the actual data on it.
Okay, thank you.
Mm-hmm.
And Dr. Rausch, in his text comment, Dr. Wolf, as a DO, your first, Dr. Rausch's DO, your first topics about manipulation remind me how useful OMM can be as a pain adjuvant. And I'm just going to interrupt the thread there because I've seen that. We have a lot of people, and even that come into this fellowship program with osteopathic training, and yet somehow the osteopathic portion of that training seems to fall to the wayside. That's just more of a comment. I'll continue with his note. Even using indirect or more gentle techniques for patients with pathological fractures to encourage lymph flow, local tissue response, etc., and for patients who cannot participate in PTOT or are bedridden. Several referral sources are limited in the area, but a consideration still. If anyone has any reputable referral sources, do share. So Garrett, I'm just gonna, if you're still online there, I can't sift through all this, all these names. Are you thinking just for people that are bedridden at home, people that are in the hospital, facilities, or what's the environment in which you're anticipating?
I was considering all of the above. My current work in our cancer clinic, I've thought of multiple patients who have gone and seen the acupuncturist with good results, thinking that whether it be me that provide the OMM or a referral source could be beneficial. But also even in the hospital, patients with pain that have been bedridden in the hospital for several days, weeks, or months on end, and even considering in the home hospice atmosphere as well too, patients that have more pain secondary to their debility, or maybe are having intolerable side effects to medicines. Well, I don't always see it as a complete solution for their pain. It could be a piece of many of our patients' pain puzzles.
Do you have any thoughts on that, Andrea, in terms of just resources?
Yeah, there's one acupuncturist, traditional Chinese medicine doc that I work with. I honestly don't know of another one. There's a number of naturopaths in the area. And then there's one DO who does a lot of OMM that I can't think of the name of right now. I think he's somewhere in the Beltline. I'll have to look into that.
Dr. Wolf, that was my knowledge too, is there's a MSU practice on the Beltline that could be a potential referral source. I believe in working with Dr. Phillips, we may have sent a patient to them at one point. Joel, you may have
so I
more
actually
updated info.
Bookmarked on my Internet Explorer here. So the MSU clinic is now the Visker clinic, VISG. I get it right for you, GER. And they've got actually clinics in Grand Rapids, Muskegon, and Holland. So that's where I've been sending a lot of people. But there is another one that I will use, Dr. Chadfield. So the Chadfield clinic does quite a bit as well. So those are the two that I tend to go to. And I just want to comment that, I mean, OMM, I love the stuff myself. And what I tell patients is I really run out of time. This has almost really become a specialty unto its own. And I'd love to be able to have that time to practice it and do it. But so much is always new and changing in the field that I find it often I've got to refer to somebody else who can take it on. But even then, there's just not enough people practicing OMM in the area. And either people will get limited visits, like maybe 3 to 4 visits, or maybe there'll be a wait list. So if anybody's interested in taking this up and doing more of it, I think it's a valuable resource in the community, and we need more.
You know, and just something, and I'm just kind of really thinking out loud here without maybe thinking before speaking, but there has been, and maybe still is, an OMM residency over at U of M Health West. And if that still exists, I don't know, Steve, are you still on the call? You may know if that still exists over there or not. If it does, it just, I wonder if there's a possibility of partnering with them. I'm sure that they have some sort of a clinic structure for their residency program, and if they would accept referrals from, from our ilk, when we have patients that we feel could benefit from something like that.
Yeah, Dr. Grunwald was the program director.
Grunwald?
Grunwald.
Oh, okay, yeah.
He was the program director for that fellowship. I don't know if that's still going on or not.
I actually graduated from that fellowship. I'm sorry, from that residency, and secondary to leadership changes at U of M Health West, they no longer have the OMM specific track as a part of their residency. They still remain OMM focused.
That's very unfortunate.
It is.
Where are they supposed to get the education?
I know. Well, and they used to have an inpatient rounding service as well too. For example, patients that had NG tubes would have a lot of cervical pain and could treat the patients inpatient in the hospital as well. However, they still do, they might be one of our best sources for OMM referrals still, or at least to know where we could send some of these patients. So I can actually reach out. I'm still connected with program directors and keep everyone in touch because that could be a really good benefit. And I've thought about them multiple times, partnering with them with my patients with cancer pain as well too.
Yeah, you mentioned the cervical pain, dysphagia is another thing that I've treated in my office as well.
Andrea, it would be all right if I put your email in the chat box
Oh,
there?
yeah, I can add it there.
I'll just throw it in there. I
Okay.
expect that this is going to stimulate some thoughts that people might have, follow-up questions for you, referrals perhaps. There's a lot that we need to learn about this, and we'll have to see. When might need to bring you back in the spring too for a follow-up as we dive deeper into this.
I hate to ask, but are some of these therapies covered under insurance or not usually?
Usually what I provide billing codes for is the time.
Okay.
So the hyperbaric insurance doesn't cover it if it's under 1.4 atmospheres. So for my chamber, it wouldn't be covered, but the other things I can bill time-based.
All right, other questions for Dr. Wolf? Well, thank you so much, Andrea. This has been a great insightful lecture, and we just those around our table I know are greatly appreciative of that.
Yeah,
so thank you
very much.